Hello everyone, I am Rifat and welcoming you to the second lecture of this health insurance course. This lecture will cover two chapters from the health reform book. One is chapter 5 that covers the goals for evaluating health systems, and the another is chapter 6 which is on assessing health system performance. Diagnosis in chapter 7 and will be covered in the next lecture. While judging performance is based on individual values, it is useful for folks studying healthcare system to focus on a limited number of performance goals to define problems and evaluate solutions. So understanding the causes for less than satisfactory outcomes, that can be said that poor performance within a system, one can start from the intermediate outcomes. And once a policymaker has decided what performance problems to focus on, he can go to the next stage in the policy cycle, which is diagnosis. At first, one has to define the performance goals, and to pick proper performance goals, you have to know their purpose. Performance goals have to be politically relevant, that is, the government should endorse the goals, and they should reflect the main alternative philosophies on the health system that we discussed last week. And those alternative philosophies are utilitarianism, egalitarianism, and communitarianism. And last of all, we want to choose performance measures that are significantly affected by health policy choices. For example, the health sector does influence the overall level of happiness for a population. But happiness or well-being is also affected by several external factors outside the healthcare system. On the other hand, satisfaction with the health sector itself depends for the most part on what happens inside the healthcare sector. This second example meets the test of causal dependence. The first performance goal is the health status of the population. Health status meets the test of being politically correct, and it is also philosophically relevant. It is central to the concern of utilitarians who are worried about their well-being of the population. It is also a critical aspect of opportunity for egalitarian liberals who think that there are strong ethical arguments for paying attention to the health of those with poor health status. The second performance goal is the degree to which citizens are satisfied with the services provided by the health sector. This goal is in line with the subjective utilitarian view, usually favored by economists. Generally, a significant driver of reform is when the current system is unable to provide what citizens want. And the third goal is financial risk protection. This is usually a major goal of any healthcare policy, and it is usually influenced by how the health sector is financed. Spending more money does not always improve health sector performance. Most health systems are not fully efficient. On the graph, this is represented by point A. And you can see that in both axes, cost and performance are there. And for a given level of cost, you can find that a given level of performance. And B is the border beyond which the performance cannot be elevated. So from A, one can go in many directions, that is signified by the numbers and arrows. And nations in this situation, from being in the point A, have a few options. First, they can accept somewhat reduced performance in order to significantly reduce cost. Second one is, they can save as much as possible without reducing outcomes. Third option is, they can choose to improve efficiency by simultaneously lowering cost and raising performance. Fourth option, they can choose to maximize performance for the current budget where they do not increase costs. And the last one, they can improve performance to an extent where more spending is required. Going back to the issue of judging a health sector performance, I want to reiterate the three performance goals: health status, citizen satisfaction, and financial risk protection. Two kinds of tests need to be applied to evaluate a nation's achievement in each of these areas. The first test is the average performance of a health system, and the second one is measuring how the system does with the issue of equity. And besides the role of costs in shaping the judgments about the performance of health system, another factor is the influence of social and political processes. While costs, especially cost increases, usually kickstart the reform process, it is the culture and politics that shape problem definition and set priorities and the kinds of choices that a nation makes during the reform process. In order to understand the causes of unsatisfactory outcomes, that can be said that poor performances, one has to be interested in some intermediate performance measures before one can get to the ultimate outcomes. The author of this book discussed three intermediate outcomes. Those are efficiency, access, and quality. Efficiency has been defined in so many different ways. Efficiency has acquired substantial value as an apparently uncontroversial objective. Who doesn't want more value? There are two types of efficiency. One is technical efficiency and the other is allocative efficiency. Technical efficiency refers to situations in which a good or a service is produced at minimum cost. For example, we want to get the cost per day at a hospital to be as low as possible. On the other hand, allocative efficiency deals with whether a nation is producing the right collection of outputs to achieve its overall goals or maximize consumer satisfaction. For example, health planners may be interested in understanding which set of services maximize patient satisfaction. Access is always a major concern of any health system. A lack of access is often introduced as a cause of poor health status in rural areas or of low levels of satisfaction among the poor. Sometimes access simply refers to whether services are offered in a specific area. This is called physical availability. The second notion of access deals effective ability, or how easy it is for citizens to get care in the health system. The third intermediate performance measure is quality. Like access, quality is not valuable in and of itself, but actually for the role it plays in achieving the ultimate performance goals. Generally, there are three major uses of the term quality. First, quality can be used to mean simply the quantity of care provided to a patient, meaning the more care a patient gets, the higher the quality of care. Second is clinical quality. This involves both the skill of caregivers, like that of a surgeon, and getting the correct diagnosis and treatment decisions. And the last one is service quality. The subcategories here are all multi-dimensional. When it comes to quality, the question you should ask is whether the service that is being produced is resulting in the highest possible quality given the costs. In the graphs above, we assume that service quality and clinical quality are each a single measure. This gives two dimensions. You can complicate things by adding more dimensions of each quality type. So the way diagram 1 is drawn shows that for a specified level of spending per unit of service, any medical care system can only produce a limited level of clinical or service quality. In diagram 1, if either service or clinical quality is too low, the other aspect of quality suffers. But the key here is that to be technically efficient, you have to produce on the frontier. So points X, Y, Z are technically efficient, but A is not. The argument here is that although the process of health reform usually starts with events outside your control, you should still try to influence the problem definition. You could start with what you want to accomplish and then see if there is a technically feasible and politically acceptable way to make that happen. One way for reformers to proceed is through benchmarking. or comparing national performance with different standards to see where performance is inadequate and where improvements can take place. There are different types of benchmarking. Those are ethical, internal, historical, external. So this ends our discussion on evaluation of health systems and assessing health systems. For the next class, we will go to the diagnosing of these problems. Thank you.